questions? So, sorry?
Okay, with that, we're going to move on to our next talk. Christoph Karmanek is going to deliver this talk about the classification of peripheral artery disease plaque composition using 9.4 Tesla and artificial intelligence algorithm.
Thanks for the introduction. Pleasure to be here on this last day. And I would like to talk here about applying an algorithm. I mean, this is really at the core of that, and we'll hear a little bit more from the consecutive talks here by our visiting a physician here, Dr. Jory. So she is here, and I'm just giving this talk here. So at the core of the matter is peripheral arterial disease plaque analysis. And as you all know about that, right? And so what we use for MRI for, right? We look at composition. But more specifically here, the interest is really for a particular application, and this is crossability and endovascular treatment, right? So what it gets down to is the plaque hard tissue, soft tissue, right? Very, very easy. So not looking at the complexity, not looking at the whole composition. We had great talks here, the earlier days, carotid plaque composition and so forth, but here's a very well-defined application. An example here, and this was done on actually plaques excised from amputated legs and measured on 9.4 program. And you look here, UTE, T2, of course, right? An example here, histology giving us the ground truth, thrombus, right? T2 dark, so what is it? As a calcification. Of course, micro-CT shows us it's not, right? But UTE is great, I think. It really shows us it's iso-intense, so no hyper-intense, iso-intense signal. So it's soft tissue, right? It's crossable. So if you look at that, you probably agree with me more or less, and I'll bring this up here a little bit. But you know how we talked about how we bring this over to people that are not trained in that field, right? I mean, this is difficult if you look to other specialties, right? And how we get this over. And so the idea here, and you know this is what I talked about, right? We have the 9.4 program where we want to develop this method. And again, we'll hear in the other talks a little bit about migrating that actually to more clinical applications here. So then the idea was here to actually use an algorithm, and we have all heard about artificial intelligence. I like to think of it as a tool, right? And there's different algorithms in there we can use as tools. And hopefully, I'm not sure, I mean, maybe you know about these variational order encoders, but they're great because the variational order encoders have an intrinsic method of checking their performance, right? So essentially, what you do, you have input, and it's shown there, right? And colored images here, the idea here just being using RGB images, and each component is from a MRI contrast, right? And then we have 2D convolution neural network here, and just shown by these two blocks here, no details, right? But you're essentially compressing the information in those images, or extracting, I'd like to say, the information in those images into what we like to think of as a latent space, and in this particular case, actually two-dimensional latent space. And then once we've done all that, right, we trained the encoder, we got our latent space here. We actually have a decoder from that data, from the latent space, then extracts the information and creates an output. Now, of course, the check, of course, would be to see how close is the output to the input, right? So it's a very automated system, or very automated algorithm. Don't need to label any images, which I kind of liked, right? So, and it's really something self-sufficient, self-contained. And the advantage is you end up with a latent space. And in a latent space, then you can do a classification, right? So once you are confident, and this is checking the output versus the input, how well the algorithm functions or works, then you can go to the latent space and trying to see if you can do some classification. So in other words, you look at the areas in the latent space and you classify them by, in this particular case, for this particular application, patent occluded with soft tissue, occluded with soft and hard tissue, and occluded with hard tissue. And we all like scores, so we put a numerical score to that. So the interesting idea here is, again, to condense the image information, again, for a particular application, into a numerical value, into a score. And, well, luckily, right, we do have histology. So histology here, and that's shown down there in the third step, these are actually images that are reconstructed, or the output of the algorithm, and see, I mean, is it actually usable? Is it confident? This is confident, right? I mean, I would not trust an AI algorithm to perform well unless I have a more traditional method to verify the output, right? And so, all right, so that's I'm summarizing what I just hopefully brought over. And again, it's for optimal treatment planning and device selection. So the idea is really to get to the point how we can actually translate that. Right? So, I mean, details here, right? And the interesting thing is also, so we have 6 lesions. How you get to 4,000 images? Or you get to 4,000 images if you acquire them axial slices, thin slices. You can actually use every single slice in training the algorithm. So that allows us then to get to a high volume, really avoiding to have a large number of patients or lesions here. So it's really by the slices. And a little bit here to the colors, if they're unfamiliar. This is a latent space, and this is what a latent space looks like if you attribute an image to every point in the latent space. And the red boxes here then going to what I mentioned before, classifying or selecting the latent space to classify the tissue. And what you see in the upper left, it's the dark, right, black, right, that's calcification, right, so hard and soft tissue. But if you look down on the lower left, the other box there, center is black, right, so hard tissue occlusion, right, and the rest, we all say soft tissue occlusion. There's less of calcification, less of dark. So at the end of the day, we're not making a claim to say we reconstruct every single component here, but we really look at hard, soft. And so also we are confident staying in the two-dimensional latent space here to make sure the algorithm, it's not overly, there would be going to higher dimensions, but for this particular case, we're looking at two conditions more or less, right? So how you go back to that, so what you could do then, and it's shown here in this slide, what you do, this is the axial cross-section of each of these tissues, right? Sagittal cross-section of each of these tissues. They have different segments, and the score up there is shown in this bar chart there on the top. And you see on the one on the left, right, very high scores, and the one on the right, very low scores, and black versus not black, right? So we can attribute to each of those tissues a score, right? And luckily, what we ended up with these different tissues here, we had a large variety of the different components. So it was not homogeneous samples, so we had large variety to train the algorithm as well. Again, looking again what I mentioned before, looking at slices here to see how is the algorithm actually performing, and that's something we're just setting up. So we just got started on that, and we'll evaluate a little bit further on that. But we're kind of confident we succeeded in making this algorithm work. So with that, I would like to So with this, I'd like to thank Variation Audio can be trained to identify the tissue properties for our purpose only, right? And an optimized algorithm, right, we'll test that with histology, with the ground truth, right? And of course, we are going to put a little bit of work into this, actually to apply it clinically. But this is an example here I wanted to bring across with the presentation, and I'd like to thank you for your attention. Thanks.
Thanks very much, Christoph, not just for presenting this excellent work, but for keeping on time.
Thank you.
While we're waiting for questions from the audience, I'd like to ask you a question.
Yeah.
Have you tried downgrading spatial resolution of your 9.4 Tesla to simulate the potential, clinical application in vivo rather than using beautiful setup at 9.4 ex vivo?
So when correct, right? Here again, the point really being more or less is to look at, calcified or dark versus not dark, right? And so the spatial resolution may be of a lesser importance here, right? To see a performance or see a successful performance of the algorithm. It's really something that at the end of the day, right? When you talk about spatial resolution, is information content, right? And that also goes then computation time and things like this. And the first attempt here was successful, I think, right? But yes, good point. To increase spatial resolution, not downgrading spatial resolution for any of those applications.
This is very helpful, but the question was related to potential translation to in vivo, to looking at clinical.
And we'll hear about this in the next two talks.
Okay.
So a little bit of that as well. So taking away from that, yeah.
Okay, thanks very much. Do we have another question, please?
Well, thanks for the perfect presentation, and I have a question about the fusion of histology and the in vivo MRI images. Like since after sacrifice, the lumen may shrink, and I want to know what's your experience about the fusion of maybe the bigger in vivo MRI images of the lumen and vessel walls and the smaller histology. Thank you.
So basically relating histology to in vivo, right?
Yeah, right.
I refer to the next talks. Oh. No, really, sorry, I want to take away the in vivo component of the following talks, right? And okay, all right, okay, a little bit, right? So we also did apply this to trying to use in vivo there. And for in vivo, you have to differentiate a little bit. We are lucky to have a 7 Tesla, and we actually do PAD imaging on a 7 Tesla, higher resolution. And from there, we learned how to translate that to the 3 Tesla. And it's reasonably well working again with the idea only, right? Crossability, non-crossability. And all the other information contained in the 9.4, right, is a little bit, I mean, there's a lot of more to do, a lot of more potential here, right? And also with histology, right? But here we're really, after one effect, and I don't want to say simple here, right, because the application is complex, right? But the imaging instruction with the 2D convolutional neural networks are straightforward for this particular application. We can talk more offline, because we're holding up the tour.
Thanks
you know,
very
to-
much.
to
Thanks
the bay
Thank you
and
very
all
much.
that. Okay, thanks so much.
Okay. So we are now going to see how this all works at 70. Now, next presenter is Judith Xor from Houston Methodist Hospital.
So, hello everyone. Thank you for being here. And my name is Judith Xor. I'm working with Dr. Trisha Roy and with Dr. Christoph Karmonik at the Houston Methodist Hospital. And our lab is working on developing and using advanced imaging technologies and deliver care that is precisely tailored to the needs of each patient. Of peripheral artery disease patients. And I'm glad to present our recent results on how MRI histology method can aid device selection and treatment planning in this patient population particularly. So here are our disclosures. So MRI still remains under-recognized method in the diagnosis of PAD. However, it shows immense promise in addressing critical knowledge gaps for effective treatment planning. Both the Global Vascular Guidelines of Society of Vascular Surgery and the NICA guidelines for chronically limb-threatening ischemia patients underscore the urgency of advancing non-invasive PAD imaging, particularly using MRI. The recent BESCLI study also showed that bypass surgery is usually better for patients with an adequate single saphenous vein, which called the usual endovascular first approach into question. So our goal with our new MRI histology method was to personalize treatment planning. What is important regarding personalized treatment planning? First, to choose the appropriate patients who should go to PVI and who should go to bypass surgery directly. Second, to choose the appropriate devices for PVI procedures, and third, we should choose the right size of the devices for the PVI procedures. So in the PAD management, imaging is often essential for accurate diagnosis and therapy planning, and these include invasive and non-invasive imaging methods. Invasive includes DSA and IVUS, which are normally used for device sizing in PAD patients for PVI procedures. But being an invasive modality, however, it may cause complications during the procedure. On the non-invasive side, we have duplex ultrasound, CTA, MRI, but all of these methods has their own limitations. And emerging non-contrast MRI methods like KISS MRI has already showed their potential in revealing lower extremity arterial anatomy, localizing lesions, but and also evaluating the degree of stenosis, but revealing plaque morphology is still a limitation for most of these techniques. MRI luckily has the potential and this unique capability of revealing soft tissue and hard tissue properties, as Dr. Karmonik already mentioned. And a bit more detail why it is matter in PAD patients. While MRI studies usually focus on coronary and carotid arteries, our MRI histology protocol is now trying to pioneer applications that are usually characterized PAD lesions. And PAD lesions can be very complex, can be composed of soft and hard tissue components, hard as calcium or dense collagen, soft as thrombus. And percutaneous vascular interventions are limited by these plaque components. So with these current imaging methods that struggle to reliably detect these hard lesions can lead ultimately to suboptimal patient and device selection and device sizing. Detailed knowledge of the plaque structure can aid personalized treatment planning in the future, in our opinion. So here is a very nice example on how MRI can help other imaging modalities in evaluating detailed plaque properties. On the left, you can see anterior tibial artery lesion as an example using 7 Tesla magnetic MRI images, CTA, and on the left, on the right, you can see an occluded posterior tibial artery with DSA and ultrasound. The assessment of the CTA images on the left are limited in cases of severely calcified vessel, like here, due to blooming artifacts. And for example, on the left, in the case of occluded posterior tibial artery, we can see that the ultrasound couldn't reveal plaque morphology because the acoustic shadowing decreased the image quality and didn't allow the examiner to see the detailed plaque morphology. On the DSC, the plaque morphology is also limited. Usually we can see somewhat of the calcified plaques, but not the detailed plaque properties. So in the Houston Methodist Hospital, we are using this high fidelity amputated leg model to evaluate the feasibility of our MRI histology protocol and aiding device and patient selection. We are using multiple different imaging modalities, hybrid OR experiment, and also histologic analysis for validation. Regarding MRI histology, our protocol consists multiple different imaging contrasts, such as ultra-short echo time, T1 and T2 weighted sequences. We evaluate the lower extremity plaques using these multi-contrast acquisition. And we also evaluate penetrability and lesion sizes, lesion metrics as lesion length and vessel diameters. So our MRI protocol provides sufficient soft tissue contrast to analyze plaque components, and it is also able to differentiate between hard and soft lesion components, which is based on the different echo times of collagenous and calcified tissues. Usually we scan the leg either before or after the amputation, and we use to localize target lesions these 3D curved multiplanar reconstructions before taking the leg in the hybrid OR for further experiments. In the hybrid operating room, after MRI imaging, vascular surgeons and radiologists cooperate on a multi-level evaluation utilizing different imaging techniques such as cone beam CT, DSA, IVUS, and we also perform experiments with different vessel preparation devices. And we have devised this novel model for impartial and robust assessment of PVI devices, considering their direct mechanical effects on the vessel wall, also considering their size to personalize device choices and treatment planning for these PAD patients. Current device testing methods often relies on unrealistic animal models and creating a gap between preclinical trials and clinical reality. That's the question that we wanted to answer with our amputated leg model. By characterizing lesions before the device use and citing MRI histology with our MRI histology protocol, we aim to distinguish patients who stand to the benefit from those who might face harm during the treatment. So this current study, we focused on how MRI can tailor device sizing compared to the conventional device sizing methods such as IVUS and DSA, and vessel preparation for PVIs are an integral part of the procedural planning, allowing for optimal lumen gain, minimizing vascular trauma, and readying vessels for stent and drug delivery during PVI. Here we used 7 amputated legs with 16 lesions, and we scanned these amputated legs at a 70 magneton bead scanner with a 200 micron isotropic resolution, and we performed our measurements on the ultra short echo time contrast. And we took the legs to the hybrid OR, where we performed the aforementioned DSA and IVUS experiments. And for the measurements, we measured reference vessel diameter, we measured the optimal balance size, we measured the diameter at the site of the stenosis, and we also evaluated calcified plaque distribution. So how to compare two-dimensional and three-dimensional data? That's always a question. In our case, we used bony landmarks. Bony landmarks are usually stationary in relation to the vessels, both in vivo and ex vivo. So such as bony structures such as the medial malleolus or tibial plateau or fibular head can be used for measurements and localizing lesions in 2D and 3D data. So the initial registration, for the initial registration, we used manual alignment of these 2D and 3D X-ray and MRI images. And for the enhanced accuracy, we also used the aforementioned curved multiplanar reconstructions of the treated vessels. So in summary, our results showed that MRI, IVUS, and DSA correlated pretty well regarding stenosis diameter, reference vessel diameter, degree of stenosis, and balloon size. However, it's not mentioning that MRI tended to be more similar to the measurements with DSA and was slightly lower than the measurements with IVUS. In this particular model and in vivo, during IVUS, they usually use saline to inflate the vessel, which might be able to bias the results ultimately. But the conclusion and the most exciting part of our experiment was the multimodality approach. And with IVUS, MRI, and DSA, we are trying to optimize which would be the best device and what would be the best size to optimize treatment planning.
This is excellent. Judith, I think you should start talking
about the next
your
one.
second piece of work.
Yeah,
this is fascinating, and I could listen to you for hours.
Thank
but
you.
We have to try
Yeah,
and wrap up.
changing
so if you go quickly into,
I will
into
go
your pitch,
ahead for the next one. So, in conclusion, further evaluation is needed on a larger patient population in vivo, and MRI is still an outstanding tool in pre-procedural decision-making, device selection in PAD patients, and I would head to the next experiment on crossability, not only on device testing, to show how we could improve the outcomes of PVI procedures. Thank you.
Thank you. In the interest of time, we're moving on right away to the last 4 presentations are going to be power pitches, 3 minutes long. The first one will be given by the same presenter, Judith Xor, assessment of peripheral artery disease, lesion characteristics and crossability using high-resolution 7 Tesla magnetic resonance histology.
So, continuing our revealing how our MRI histology method can aid personalized treatment planning for PAD. I already mentioned the BEST-CLI trial where patients with adequate VIN showed better outcomes with patients with endovascular first approach, and this trial showed a 15 to 20% immediate technical failure. So another thing that this BEST-CLI trial trying to enhance is the need of better clarify contemporary CLTI populations, treatment offers, and expected outcomes to identify patients that would benefit the most from bypass or endo as a primary strategy. Looking at this immediate technical failure rate, the best would be to identify those patients who would be an immediate failure directly using imaging methods. And developing these new MRI methods can help us ultimately to identify these uncrossable lesions in PAD patients. So for our crossability study, for this particularly, we evaluated 8 vessels, which were characterized in detail from 6 amputated legs, and we performed the same 200 micron isotropic UTE sequence on 7 Tesla MRI scanner. We identified soft, like loose fibrous or tissue thrombus, fat, or microchannels, and we also identified hard, like calcified or dense collagen structures. And after evaluating the MRI data sets, lesions were characterized as non-crossable if more than 50% of the lumen was occluded with calcium or dense collagen, like hard structures. Lesion length was classified as short, intermediate, or long, and the level of calcification, like non, mild, or moderate, or severe, was also reported, as well as the distribution of calcium on the vessels. Following the MRI, the aforementioned hybrid OR PVI experiment was performed using different imaging methods, multimodality approach, DSI, and crossability testing. And here is a very nice example how a crossable and an uncrossable lesion can be identified at 7 Tesla images. So if you take a look at the left picture, you can see that there is a calcified nodule which, even if an eccentric depth distribution causes mild stenosis, but the stenosis isn't higher than 50%. And this MRI image also revealed a deep venous thrombosis in both lower extremity veins, and you can see the nerves beautifully coming along with the vessels in the lower extremity. On the curved multiplanar reconstruction, you can see that the lumen is hyperintense, so it means that this lesion was crossable on UTE. On the
Please
other
come
hand,
to your summary soon.
Yeah, sorry. So looking at this picture, the lesion was non-crossable in the lumen, occluded with hard, hyperintense tissue. And in conclusion, of the 4 lesions, 6 were scored as crossable, 2 were scored as non-crossable, and MRI scores identified crossable and not crossable lesions with a 100% accuracy compared to the outcomes of the procedures which we performed in the hybrid OR. The two lesions marked with red were immediate technical failures. In one case, the physician could not cross the lesion subintimally, but could cross the lesion subintimally, but could not cross the lumen, could not re-enter the lumen afterwards. And in conclusion, this is really just the beginning, proving that our custom-made proving that our MRI histology algorithm can identify and differentiate tissue properties. And this MRI histology allows us to see PAD lesions in their complexity. And here we presented 9.40 and 70 results, but we are also building up 3T and 1.5T studies. And this is our most recent study on in vivo revascularization patients, where we compared TASC and GLASS scoring to our MRI scoring system. And our MRI histology scoring system was the only factor that significantly was associated with crossability compared to these conventional scoring systems. So we can say that our MRI histology was able to reliably identify PVI patients and initial crossing failures and complex interventions in a widely available in vivo setup as well. So we translated eventually our method into the patient care.
Thank you,
Thank
Dr. Zor. The next presentation will be given by Hao Li from Fudan University. Visualization of foot vessel improved by warm water immersion using non-contrast enhanced MRA on a 5-Tesla system.
Thank you for introduction. Good morning. I'm Hao Li from Fudan University. So in this work, we perform non-contrast enhanced MRA on feet using a 5T system, and we improve the visualization by warm water immersion. As we know, limb ischemia is a common peripheral artery disease, especially on feet. Several different non-contrast enhanced techniques have been implemented on foot MRA, but most of them are flow dependent. So there will be a challenge, which is about the slow blood flow on the feet, which could result in insufficient blood flow, insufficient blood signal. So in this work, we try to solve this problem by using a simple but very effective method, which is to ask the patients to immerse their feet in warm water for around 10 minutes. And as for the acquisition, we used a 5T system from United Imaging. In our previous study, we demonstrated that it has superior performance in intracranial TOF MRI. So in this study, we used it to scan the feet. And the sequence we used is 3D phase contrast MRI, which is not a new technique, but we found it less sensitive to the field homogeneity of ultra-high field system. We recruited 20 participants, including healthy volunteers and several patients, and 6 of them reported with cold sensitivity, which means that they often feel discomfort when their feet are exposed to cold. And we developed this quantitative analysis method. And let's look at the results. For subjects with cold sensitivity, we can see that PCMI could not visualize the arteries very well because of the slow blood flow. But after warm water immersion, the visualization was greatly improved, including those small distal arteries. And here are some quantitative measurements which have all increased. Another good thing about PCMI is that we can estimate the velocity, and we can see that the velocity increased after warm water immersion, which explains the reason of the improved visualization. And for subjects without cold sensitivity, the PCMI itself can generate good angiograms, but it can be further improved by warm water immersion. And here are 2 cases for patients. The left figure shows a patient with varicose veins, which can be seen more clearly after warm water immersion. And the right case shows a patient with stenosis and ischemia. We can see that the blood flow is very slow before warm water immersion, but the blood flow and the visualization was greatly improved after warm water immersion. We have some more detailed quantitative results which can be seen in future publications if you are interested. So in conclusion, 3D PCMRE is an effective method for visualizing foot vessels at 5T, and warm water immersion can significantly increase the flow velocity and result in enhanced blood signal and improved visualization of distal small branches, particularly for participants with cold sensitivity. We'd like to thank you very much for your attention.
Thank you very much. The next presentation will be given by Rong Zhu from the Chinese Academy of Science. It's called Automated Modeling and Morphologic Analysis of Deep Medullary Veins at 7 Tesla MRI in Patients with Cognitive Impairment.
Thanks very much for introduction. The topic I'm presenting today is about automated modeling and morphological analysis of deep medullary vein at 7 Tesla MRI in patients with cognitive impairments. On behalf of my student, the first author, Zhixin Li. So, according to literature report, it is believed that abnormality of the deep medullary veins may be involved in various forms of cerebral small vessel diseases, such as Alzheimer's disease and CADASIL patients. And the DVM scores correlate well with the other index, such as white matter hyperintensity, cerebral microbleeding, perivascular space, and lateral infarction. However, the automated segmentation algorithms are not perfect to characterize some deep medullary veins. You can see in this red circles. So a better or more robust automated segmentation and tracking method should be developed to give a better characterization of this DVM. In this study, we have included 17 patients with CI disease and also 18 healthy controls. The patients are evaluated with this MMSE form. The images were acquired on the 70 Siemens research MR system with a NOVA volume excitation 32-channel receive head coil. And this flowchart shows the procedure for segmentation and also tracking. Mainly, we applied a multi-input residual neural network model for auto-segmentation with multiple inputs, including both the magnetic image and the face image and one hazing matrix. The tracking was confined to these energy loss functions with various criteria. For the segmentation, we have the GRE, actually the image are based on the T1 weighted and GRE images. The GRE images have 5 echoes, so the multi-inputs have the 5 magnitude. The small patch include 5 magnitude maps and face images from the 5 GRE echoes in GRE images. And a large patch on magnitude image on the 3rd echo gives us more spatial localization. This Hessian matrix can define this judgment for the vessel. The results shows the better dice index with this multi-input residual neural network. The training accuracy, and this is the validation accuracy. The tracking actually based on the expansion of the ventricular surface of the CSF to this red lines. That gives us the starting point of the veins by this intersection of the searching for the intersection of the starting point of the vessel. And then the following of the vessel also need to consider this distance to the starting point, or we said end point here, and then also consider the angles to the previous vector angles. So this is the energy loss function. And here we show the examples of the tracking results on both the health control and the patients. It's all DVMs or tracked out by this method, which kind of solved the previous problem we mentioned in the beginning. And the quantitative evaluation of the group of patients and controls, they both have significant difference in the MMSE scores. Also, the amount or length of the DVMs are significantly different, and also the curvature. There's also a significant difference of the curvature in patients with the star p-values. In conclusion, as shown in the figure, we can see this number and curvature of DVMs not only have significant difference between patient and control, they also correlate well with the MMSE scores. Therefore, the results, the method suggests we may apply this as a potential index to correlate with the progression of the CI disease of brain. So, yeah, brain disease. Thank you very much.
Thank you. That brings us to the last power pitch in this session. Nan Gao from Tsinghua University will be presenting on heart saturation technique for in vivo atherosclerosis plaque MRI on apolipoprotein E deficient mice.
Well, thanks for the introduction. My name is Nan Gao from Tsinghua University. Today I will talk about our recent work on atherosclerosis plaque MRI on ApoE mice. And here is a brief background. With the animal models and ultra-high field MRI scanners, preclinical studies can help drug development, translational research, and disease mechanism understanding. However, MRA and vessel wall imaging on mice face several challenges. The first one is the thickness of the vessel walls is only in the size of tens micrometers. The second, mice have much faster respiration and heart rate than humans. The third, fewer RF channels and fast acquisition methods available on small animal MRI scanners. The last but not least, the signal variation caused by contrast agent. So our purpose is to develop an efficient and practical MRA and vessel wall imaging method for assessment of AS plaque on animal models, preferably useful for both endogenous and exogenous contrast agents. And we proposed a pretty straightforward method. It's a heart-saturated spatial saturation band. We call it HS, which can achieve black blood and reduce FOB at the same time. And here goes the results. The first part is endogenous contrast agent. HS T1-weighted images can achieve black blood and reduce the FOB at the same time. And goes for HS-TOF, can also achieve black blood and reduce the FOB at the same time. And according to the Furin result, the hyperintense signals in both two sequences indicate the presence of AS plaque at the same position. And it goes to the second part is exogenous contrast agent. We show the evolution of signal intensity and enhanced area of AS plaque after injection of GPCA. And HS T1-weighted images and HS-TOF have the same trend in signal intensity of AS plaque. They both reach the peak at post-injection 1 hour. And moreover, compared to the HS T1-weighted images, HS-TOF has larger enhanced areas, leading to more accurate and easier quantification. And its time to peak is consistent with signal intensity. We also did HS-DCE. The signal intensity of AS plaque increases and reaches the peak at around 20 seconds after injection and then decrease. So as a conclusion, HS technique can achieve high resolution AS plaque MRA and vessel wall imaging and is promising for the development of AS contrast agents and drugs. And for acknowledgement, this project has been supported by this fund, and I appreciate my mentor, Professor Xiaolei Song, our MR engineer, Dr. Yuqing Wang, and also Tsinghua THBI. Our booth is number 96. Thank you for your attention.
Thank you. With this, I would like to conclude this session and thank all our excellent keynote speakers and abstract presenters for sharing their recent research insights with us. Unfortunately, we didn't have enough time for discussion,